like they're gonna get a new one in like 2 years, but it's just a whole new computer system. So
Gotcha.
it's like I'm unnecessarily slow.
Wow. I hear like some doctors were saying when they went to electronic medical records, it was quite the.
I mean, old timers have a problem with it, but it's more just like when I look at an MRI, I can't move as quickly as I normally could because I just don't know the buttons and the function of the viewing system. So
Gotcha.
it takes a good 3 or 4 weeks. Like I had to learn a new one for fellowship too, but that was a really good one. This one's like an older one, so it is what it is.
Okay. We'll give it about a minute and then we'll get started. Let everybody come in.
All right.
For those who are coming in, we're just going to get started in about a minute. Just let people come in. Until then, if you guys want to drop where you guys are from in chat, and that'd be really cool. What grade you guys are and where you guys from. Okay. All right, I'm going to get started. Hello, everybody. Today is our call with Dr. Thomas. Before I get started into the call, I just have a few announcements that I want to get through, and then we'll get going with the call. Beginning with verification of the hour. The date that's up there, June 15th, that was the due date for all calls that were in call through spring. So if you're new here, I'll really quickly explain what verification of hours really means. So after today's call, what you can do is you can write us a short summary and send us via email. All of that information is posted in the bio. And what you'll get is you can get a certificate of attendance showing that you attended it. You might need this for your school, like if there's you need your hours, but we'll do that. But we ask that you wait until the end of the summer that we'll do, and we'll put the date out when they're all will be due. It's usually about like anywhere from 10 to 15 calls, more or less. Again, it's not an exact number. Sometimes calls happen, sometimes there's delays, but it'll be that. And you can send them all together. That way, it's just easier for us to process them all together in one email, and we'll just send them out right away. But we'll post a specific date when we get closer to it. We just got into Zooming through summer, so we got quite some time. But you can only do verification for Zooming through summer. So starting with calls that happen, there's one call that happened before. So starting with that, you can do verification of those calls. But you're free to still watch the previous calls that we've done, but the verification is closed at this time. If you're looking to volunteer, we also have official club med.volunteering. I know COVID still impacts everybody in their own way, so volunteering might be open, it might not be open. So if you're looking to get some hours from your house, please should check us out. There's like different programs that you can be a part of to get your hours, and all information about what programs are offered and how you can sign up and how to sign up is all posted in the bio of at Official Club Med Volunteering. And if you have any questions about anything, you can always DM us on Instagram and we'll get back to you as quickly as possible. All right, we'll move forward with Dr. Thomas. Dr. Thomas is a neuroradiologist. He was a neuroradiologist fellow at Johns Hopkins. He's an attending now. He completed his radiology residency from Wake Forest University, and he currently works at Radiology Associates of Clearwater. His Instagram is up on the screen at Tommy DeFato. Be sure to follow him. And Dr. Thomas.
Hey, everybody hear me? Yeah. All right. So I was told this is generally kind of people that might be interested in medical stuff, and radiology might not be a specialty here about too often. I think it's underrepresented, or at least when I went to medical school, it's definitely underrepresented represented for how often it's used and what proportion of medical decision care making, it really impacts. So just to give you an idea, so basically you go to undergrad, you take the MCAT, you do pre-med, you do 4 years of medical school, then you have to do really 6 years of training. So it's like 1 year internship, 4 years of radiology, and then almost everybody does a fellowship these days. My specialty is brain and spine, so some of the pictures I'm going to show you are a little bit geared that way. But I just want to tell you like what it entails, like what kind of person might like radiology, what person might not. And then I'm just going to show some cool cases from when I worked in Kenya, 2 out of the past 3 years, and that's it, and see what questions you guys got. So the reason I picked radiology, it's very diagnostic heavy. So I'm all interested in the puzzle. Once I know what it is, I can look up how to treat it. And for me, that's not a thing, but some people really enjoy walking patients through, cancer treatments and such like that. So you kind of figure out, are you into the puzzle or are you into the treatment? Also for me, I wanted something very broad. Diagnostic radiology, you have to keep up with everything. You have to kind of be able to talk to all the surgeons. So people think of radiology, so you look at x-rays. Well, I'm looking at body CTs for the ER for appendicitis. I'm looking at post-operative CTs to tell the surgeons what's wrong. Is there a leak in the small bowel still? I look for the strokes. I'm telling the neurologists whether they need to give blood thinners, et cetera, et cetera. So radiology is a critical step in most patients' care decision-making. A lot of times I'm the one figuring out what's wrong with the patient for the first time, and I get to tell the doctor that, and they get to be like, whoa, and then they deliver the news, et cetera. It's not super heavy on patient care. We do procedures, image-guided procedures, so biopsies of like the lungs or anything in the belly. When people have cancer, they get these ports in their chest. I'll show a picture of that later. I've put in hundreds of ports. It's kind of like a mini surgery. You do some, slicing on the skin. There's a subspecialty of radiology called interventional radiology, which is kind of splitting into its own thing, where they do more advanced procedures, like go up and get clots from the brain when people have strokes. But to just give you a general idea, it's a broad diagnostic heavy field. It's very efficient. So one thing you'll find out if you ever do go into the medical field, not even becoming a doctor, is that there's a lot of paperwork. There's a lot of talking in nursing homes. There's a lot of coordinating consults with other attendings. I had to do other services, like send them to cardiology, send them to pulmonology. I did a year of internship, and that wasn't for me. What I do for a job generally is I look at pictures, through the body, whether it's a brain MRI or an ultrasound, and I write a report. And that report is the basis for the doctors in the ER, whether they think there's something wrong, they need to go into the hospital. Obviously, they're going to be looking at labs and other things. But basically, my experience, honestly, I'm not trying to, everybody in the hospital talks about other specialties, better, for worse. But a lot of times I'll call the ER and they haven't seen the patient. They're like, which patient? They have to look at their list and they're like, oh. And I'm like, yeah, they're having a stroke right now, or they're having a bed. And they're like, oh, we better get them in, get them out of the waiting room. So it is rewarding in that way. It's also rewarding when doctors they have no idea what they're looking at. And they're like, whoa, oh my gosh, you explained that to me. I've been doing it wrong, So we are kind of a doctor's doctor. We're very specialized. I did 4 years of medical school. I was a very good medical student in my own opinion. I don't know. And I felt like I was learning a new language when I started radiology. I had to know everything from medical school because I had to have the context and I had to be able to communicate with people based on my experience during intern year. But when I looked at a chest x-ray, I was like, oh, what did the last person say? And I'm like, it kind of looks the same. And you're going to get, if you go to medical school, they're going to show you an x-ray and they're going to be like, oh, the aorta's here, this, there. And you're going to be like, this is impossible. This is crazy. And somebody's going to tell you, oh, radiology, robots are going to be doing that in 10 years. They don't know what they're talking about. If you're not talking about to a radiologist, take it with a grain of salt, because I almost didn't consider radiology based on advice like that. And then once I took my first elective during my 4th year medical school, I was like, oh my God, I can't believe I considered like anything else. So things people don't know about radiologists, we read like all kinds of modalities. So, we look at, I'll show you some examples of that. We do a lot of procedures, a lot more procedures than people realize. Basically anything with image guidance. Coronary stenting was invented by radiologists. A lot of the stuff that's done by other specialists nowadays was started by radiologists because we are the imaging experts. It's a lot to handle. You have to do a lot of studying, but you can really, honestly, just today, it's my 3rd day in my attending job. I'm learning a new computer system. I'm in a new city. I got a new dog. And then they come and tell me, you got to read arterial ultrasounds of the you know, the arm. And I feel like 4 years ago, I'd have been like, that's crazy. I didn't train for that. This isn't fair. But you kind of adapt this. You really are a lifelong learner in radiology. Some specialties, I think you can get away with your, you know, maybe your procedural experience, or just keep up with, but you really need to keep up. You need to read things people don't like about radiology. So it is a very male dominated field. There are theories as to why that is. One of them is sometimes if people have speculated, there are a couple little PubMed articles saying that maybe women just care about patient contact more. So if you need to be seeing a patient longitudinally, you need to see them in clinic, you need to know how their family's doing and this and that. There are subspecialties of radiology, like subsets, but in general, it's probably not the best field for you. If what gets you excited is the science and the pathology, and you're into technology and you're into moving fast and you're getting answers and that kind of thing, radiology might be perfect. Other things to know about radiology: very good lifestyle, controllable hours, because you're not getting called by your patients in the middle of the night. It's shift work. So I do work a handful of nights, but generally I'm working regular hours. Vacation generally is very well controlled. You know, some places get up to 14 weeks vacation, and you know, the salaries are generally good. As far as the whole, like, you know, AI is going to take over radiology, I've worked with probably the best AI software. It's nowhere close now. If anything, it really does actually make our lives easier. So if you're looking for little pulmonary nodules and you have to talk about 5 or 10 of them, it's easier when the computer just does that for you. One day, maybe AI will take it over. I really don't think it's going to affect my career. None of my colleagues are concerned. If anything, it's going to be something where it's assisting us as a tool. And even if 50 years for 100 years from now, it could do our job, there's still going to be who's going to be liable, who's going to be able to interpret the weird findings. Like the computer might misinterpret something. Who's going to be able to explain the findings to other doctors as a human can do? Who's going to make sure the computers are doing a good job? So I think every aspect of medicine is going to be impacted by AI. You know, a computer can ask questions to somebody walking in the ER or to a clinic, and they can use an algorithm just as easily. So it's one of those things where people get it in their heads, but if you don't really know about it, I wouldn't be too afraid about it as far as considering your career. So in general, that's radiology. Sometimes people are really paranoid about the physics. The physics aren't that heavy. People can squeeze by not knowing the physics. But part of being a radiologist is working with technologists, problem solving, making sure the image quality on MRIs and CTs is up to par. We're not the ones there, you know, pushing the buttons, making the CT happen. That's the technologist. But we work with them day and day. We work with the doctors. So it's really it's a broad field, but you can also become very specialized. So there are jobs where I could just read brain and spine, MRI and CT. There are jobs where I can read everything and do all kinds of procedures. My current job is great. They're letting me basically do whatever I want as long as I do enough brain and spine. So I'm not going to talk any more about that, but it is, just to recap, it is something that really does affect almost every patient in the hospital. It's something that even if you're not going to radiology, if you go into medicine, you should have some exposure, some kind of context to what radiologists do, so you can work better with them and you can kind of avoid miscommunication errors. It's a really cool field. It's like mentally stimulating. There's some specialties like dermatology that I was like, that would be cool, but I just can't get excited about it. And so I went with something that's not, it's maybe a little harder, but it's really rewarding mentally, still has good life balance and everything else. So I'm happy with it. If you have any questions, you can let me know. What I wanted to do now is just kind of for fun, you know, show some pictures. I did do 2 years of work in Kenya. They don't have an MRI machine there. The radiologists there are, honest to God, worse than second-year residents were at my residency. We had the clinicians there. They don't trust the radiologist reads. They were asking me about studies from 6 months before to look at. We have examples of studies they read over the weekend when we were kind of like, you know, I was like climbing Kilimanjaro, and they were taking over, and we came back and they're like, can you take a second look? And they were missing like somewhat basic things like strokes. So they were really, and I was a 3rd and 4th year resident when I went there. So they were really appreciative. It was really rewarding. The patients over there are very grateful. You know, they don't all expect to live till they're 150 years old, despite whatever they do to their body. So it was cool. I'll show you some impressive cases, and you can maybe get a little bit of an idea if this is something that seems cool to you. And if not, if you end up in medicine, maybe it'll give you some context and help. So I'm going to share my screen here if I can figure it out. Sorry, my dog is in the background making little whimper noises. Okay, here we go. So this is a line that I actually saw, took a picture of. This is my group, and let's go. So I just have a couple pictures. These are pretty stock images. This is just to give you an idea that we don't just read x-rays, because that's the first thing. I've been on dates and people are like, what, you're a radiologist, you read x-rays. I'm like, you know, you don't want to like be like, oh, I'm showing off, but I do a little more than that. So here's a brain MRI. I have one of my own somewhere, but I can't find it. Chest x-rays. I still find these to be like some of the most beautiful images. You really can, if you get into med school, they're going to say like, oh, this is the aorta right here. This is the left ventricle. And you're going to be like, this is bullshit. But it actually does make sense eventually. It's worth trying to learn. This diaphragm, et cetera, ribs. It's cool. Ultrasound, we cover pregnancies. We cover all the extremities. I mean, you can ultrasound basically anything that's not super, super deep in the body. You do get good at everything, but you can find a way to not do things you're not comfortable with. We have a lot of advanced imaging these days. We can reformat. So basically the CT can gather data from the whole body, very rich data, and we can process it in so many ways nowadays. We can do, this is a 3D MIP, maximal intensity presentation image of the circle of Willis, basically the major arteries that go up to the brain. So we can take a look at the arteries in three-dimensional. We can basically change colors. I can move this around left and right, up and down. I do this routinely. This isn't even like a super special thing. We can do 3D images of the skull. So for traumas, I have numerous saved files with, hey, calm down. Shh. Yeah. So, you know, sometimes this actually does assist us. Sometimes it's just for show, but this is sorry, my puppy is going nuts here. This is a new PET CT. It's a dotatate. So traditionally we use PET with glucose, but they're inventing new ways to basically find compounds that go to different places in the body. And it can go to different parts of pathology. Like certain cancers will uptake a certain, hold on one second. Let me just grab this. Hey. So basically they're inventing like new physiologic nuclear medicine scans that will have compounds that will track to certain parts of the body. Certain organs, certain types of cancer will uptake compounds, and we can get those compounds labeled with like radioactive material. So it'll go in your body, go to the place where there's a problem, and then it'll show up hot because it's giving off radiation. So these are hot lesions, we'll call them just for shorthand, that are showing up, and we can assign different colors. So the computer software is just phenomenal with radiology. This is kind of a little diagram of what we do with procedures. So I do a bunch of these CT guided procedures. We go in and we are able to take little tiny mini pictures and advance needles and then shoot them back under the CT. And we can hit 8 millimeter or smaller, even little lung nodules while the lungs are moving. You get really proficient at it. Some people would think, oh, I have a tremor, I can't do that, but you get good at it. I promise. And then here's a port. I don't have a picture of the actual surgery, but we do these little mini surgeries where we make 4 or 5 centimeter incisions and put these in and run them down the jugular vein into the heart. And people don't expect radiologists to be doing this. Sorry, this is my dog. He is freaking out right now. I don't know why. All right, so this is an example. This is just a picture of somebody running a needle through a lung lesion. I think this is actually for an ablation. So we can actually run heat or ice actually through this, and we can actually destroy tumors through a needle, advanced under CT guidance with no big incision, just a little hole. And we can actually get rid of kidney tumors, lung tumors. So it's really cool. Lots of procedures you can do. All right, so I'm going to talk now. It's 8:19. I think I got till 8:45 or 8:50. I'm just going to talk about my experiences with global health medicine, radiology, just try to show some impressive pathology. So maybe you think it's cool and maybe not. We'll see. This is just a map of this small mission hospital in Kajabi. It's about 50% staffed by Western doctors and Australian doctors, and then 50% by Kenyan doctors and staff as well. It kind of looks like a broken down old middle school, to be perfectly honest, when you're there. But so this is where I stayed. This is more where I stayed. This is the bathroom. It wasn't the nicest, didn't have warm water for about a week, but this was a really cool experience. So as I alluded to earlier, some of the radiologists there aren't, you know, as well trained, and nobody really gets mad at them when they screw up. So they got a good gig, I guess. But this is just an example of one of the studies we had over the weekend. This is a head CT. I'm not expecting anybody, of course, to know the anatomy, but you know, basically we look for strokes a lot of times when people can't move their arm. And they were like, oh no, this is normal. And you know, there's a little trick where you can change in radiology. Once you have the pictures on your computer, you can change how the contrast looks. So you can make it like, you know, higher contrast, lower contrast, darker, lighter. So if you change the contrast on this one, just to give you an example of what we can do, you can make the darker colors show up more and the lighter colors show up more. So just looking for symmetry, don't try to look at the anatomy, but you see how there's like a lighter border over here, and then that lighter border is kind of gone right here. So this is actually a stroke, and we were able to see this because we were, you know, we knew that strokes sometimes can be tricky to see unless you manipulate the windows. And that's what we did. We saw the stroke and we called and we said, hey, they missed this. This is a stroke. And they're like, oh crap, let's bring them in. Let's give them some rehab and everything. So there's a lot of knowledge to learn. This is just more of a stroke with radiology, and you can really make a difference. So this was the CT room in Kenya. They just have one CT for the whole region, really. And we're in here with the technologist. This is the head technologist. He's the only one that really knows what he's doing there, but he's a really cool guy. This is literally what the emergency room looks like. It looks like something out of Indiana Jones, in my opinion. All right, let me show you some cases. So this is just an example of a really big stroke. So sometimes we get these in the ER. It says, here's a head CT, look for a stroke. And you're basically looking for dark areas like this. The reason I had this on this presentation is that a lot of times people in there, they don't come till 6-7 days after, but we're doing a good job over here of educating people if you have slurred speech, et cetera, to go to the ER as soon as you can. And the CT is very important in the management because if you had a stroke like this, they can't give blood thinners. So we're the person that the neurologist will call and say, hey, is there a head bleed, number one? Because you can't give blood thinners. If they have a head bleed, it'll make them bleed more. That's what blood thinners do. And they also just want to know if there's, you know, a big stroke or a big mass lesion or something. So we're basically the decision point there. Anytime anybody has a stroke, they got to get head CT. They end up getting what's called a CTA, where they look at the vessels, and they end up getting an MRI. So radiologist is really integral for stroke management. Let's see. All right, this was just funny because it's the first thing they did for fires. They shout fire, fire. I thought that was funny. Let's keep moving. So here's another stroke. Sometimes they can be pretty subtle, but this dark area is not normal. You don't see it over here. You're losing this outer gray matter. So that's part of what we do. That's part of stroke CT. These are people in the waiting room there. So this is, without going too much into anatomy, if you look back at this picture, you see these little dark things. These are called ventricles. Everybody has these in their brain. They have what's called cerebrospinal fluid in them. It's important, like maintaining the balance, et cetera. So these are little kids that have ventricles that are way too big. These are huge. They're supposed to be like little crescents. Unfortunately, this is kind of common over there. This is called hydrocephalus. Sometimes people call it like water on the brain or something in pop culture. But basically, it's when those things can't drain properly because there's something blocking the drainage of the cerebrospinal fluid. And unfortunately, you can get this if you do medical stuff, you'll learn. You can get this when you have an infection during pregnancy. So if you have like cytomegalovirus or even basically anything, rubella, HIV, you can get big problems. And of course, in Africa, that happens more often, but we do with the heel. So as a radiologist, I'm here to basically tell them that there's a blockage of this and these are too big. And then sometimes they'll put something in to drain the fluid and take some of the pressure off. And then they want us to tell them if it's working or not. So that's another job that we do. Let's keep moving. It's one of my colleagues and one of their family medicine residents, just kind of looking at scans together. We do a lot of consulting where the doctors will come to our room and go over scans with us. And this is a impressive study. This is called a cephalostele. So this little newborn, basically a couple months, actually this kid was like several months old, has a hole in their skull back here. This white stuff is bone. This stuff is brain. Okay, this darker stuff is fluid. So there's a big hole in the back of their head. And this is actually a little bit of like brain. And I'm gonna put this dog back real quick. So that's a cephalocele. There's brain literally going through a defect in the skull, and it's important for the surgeons to know exactly what's going through that hole, so we can so they can treat it surgically. So this is a sagittal picture. We can take images, information, and we can put them in different planes. So this is axial, meaning like cut me like this, and this is sagittal, like cut me kind of like down the front. And you just look through pictures and you go back and forth and you look. That's what we do. And you develop search patterns. So you go really quickly up and down. You look at one organ, you look at the next organ, and it's an efficient job, but it's really cool. So this is brain going through a defect. We do consults, as I said. This is me doing a consult with one of the local doctors, showing them some problems with the hips. This is an example of trauma. So in Kenya, they have not many CT scanners, not many hospitals. People don't come for little things. And this is a bleed called an epidural hematoma. And basically people come in with really bad trauma there. But if this is missed, so you could have a smaller one. I'll show you a smaller one. If this is missed by the radiologist, patient can die because this is an arterial bleed. Let's see. So here's another one from this is a coronal view showing a bleed. This is called an epidural. And we can tell that this is epidural based on the shape. See how it's kind of like, well, I'm not going to go into it, but basically the shape, radiologists are trained to know what kind of bleed that is and how fast it's going to get bigger and how dangerous it is to the patient. So really bad trauma, they actually have bleeds on both sides of their head here. And you can't miss this, but you won't miss it if you're trained as a radiologist. And they can be a lot more subtle. So here's a fracture. I mentioned earlier, we're really good at manipulating the data after. So on the computer, I can make it so bones show up really nicely. I can make it show so that soft tissue like skin shows up really nicely. I can make it so that lungs show up nicely. And people that aren't trained don't know how to do this very well. So it's part of becoming an expert radiologist. This is just a cool picture from a place called Hell's Gate, where the Lion King was partially inspired, actually. This is a skeleton. So here's another fracture. There's actually a fracture here back behind the skull, and it runs all the way through the skull base. You don't have to know any of this anatomy, but this is getting like behind your eye and part of the bone. This is a fracture. So you get a very well-trained eye in radiology where you can find little hairline fractures, which are just basically, we call them lucencies because it's like less dense, it's lucent. It's not important. The important thing is here to see like kind of the scope of stuff we do. I talked about more subtle bleeds. So this is a more subtle bleed here. See how it's brighter here and it's got that shape right up against the bone. This patient can die if you miss this. So that's part of your job as a radiologist. Another one here. These aren't super common, these bleeds. That's why I showed them. I'm going to kind of roll through just to show some impressive cases. So over there, they don't have MRI. MRI is the main thing we use to find masses. We saw this and we said, as radiologists, if the technologist says, hey, there's something weird here, what do you want to do? We said, okay, well, we should probably give them contrast. So what contrast is something they basically get into their veins and it goes into their blood and it shows up better on the CTs because it shows up bright. So we did that. And then you can see these, so now you got a little ring around it. Let me show you that. Actually, I was trying to use my finger like an idiot. There's a little ring of brightness around it. So we problem solve as radiologists. The technologist might say, hey, do you want to get contrast? Well, yeah, we do. And then we figured out these are metastatic masses right here. And so that's part of what we do. This is part of our team. Keep moving. This is a nasty bathroom at the restaurant. Okay, here's an example of a neck CT where we found a mass right up against the carotid artery. And we know what this mass is based on the way it looks because people have done research and practiced a lot and figured out what things look like. So that's part of your training. What does this look like? And then you figure out that they're like on an MRI, for instance, you'll have different sequences that one thing will show water better. One thing will show brain material better. And you use like, it's almost like problem solving. So if you ever took those kinds of tests where you like learn one rule and then you learn another rule and you kind of put them together to figure out what things are. So it's really puzzle solving. It's problem solving. So this is a mass. You can even see these vessels are lit up, and between there's this mass. So the way I would read this mass is I would go through the whole study sequentially, like in a very organized way. And I would look at each structure and figure out, is there anything wrong with it? And obviously this mass would pop out, but there are very subtle findings. So you have to be disciplined as a radiologist, but it's not impossible. Hey, shh, down. All right, let's keep going. Sorry, I apologize, but he's not usually this crazy. Here's a sinus disease. So we look at this for ear, nose, throat doctors. This is supposed to be air filled. Air is black on here, like this one. Oh, let me grab him again. Sorry, guys. So this is actually, I can tell because the way this is bright in the middle here and the way it's got a little crescent of air, I can tell that that's a fungus ball in his sinus. It's just the way they look. I have the experience and practice. So it's really cool to be able to do this. These are all animals that I took pictures of. Just impressive masses over in Kenya. I mean, this mass is eating away the skull, that the white thing is the skull. It's going through the outer part of the brain. It's actually pushing parts of the brain in. So we also looked at the patterns here and here, and we come up with a differential diagnosis. So as a radiologist, you'll look at it and you'll say, I don't know what this is, but it's got these features, these features, these features. It could be one of three things. And so, you know, it's a lot of studying, but it's you have a lot of answers too. So you're the answer man or woman. Very impressive mass. People don't go to the hospital soon enough over there. Here's a cool study. Again, I'm focusing on brain and spine, but in the last 10 minutes, I'll switch over to body stuff. These little bumps are just abnormal. It can be that subtle. And this says that they might have even had a congenital disease. Let's keep going. Skip that. I'm gonna skip that one actually. This was a cool case. They asked me about this case. It was like 3 months before I got there, they did this case, and it got read as something called Rosai-Dorfman, which is it's like a white cell disorder where you get massive. So this is like through their neck. I don't know if you can see how big their neck is swollen right here. But basically they have these abnormal cells all here and all back here. Just trust me, this is all abnormal. It's like all growth. And they were running with this diagnosis, Rosai-Dorfman, which is a little different than what we ended up calling it. This is a coronal picture. So kind of cutting them down like sideways, I don't know. And you can see these massive growths here and all up. This is all like under your armpits here. This is the axillary regions. But, you know, as a radiologist, you say, okay, what else could this be? And so we looked at the skull and we changed the window. You can see how the bones show up differently on this picture compared to this picture where they're just purely white. So we changed the parameters so we could see these little holes in the skull. If you see this little hole, and this is a characteristic of something called Langerhans cell histiocytosis, which is a different diagnosis and different treatment. So you just learn all the patterns and all the tricks, and you just read a lot of studies, and you see all the cool cases in the hospital every day because they get pictures. Well, this one was just interesting. These are, you don't have to know, but these are the thalamus, whatever, and they're kind of fused here. There should be split in the middle. So this person probably didn't even have they had a congenital problem. Sometimes people over there don't have enough folate as well. So like that earlier one with the brain coming out of the back of the head, they didn't have enough folate. And the reason I talk about that is because it's important to know like what kind of things are going on where you live. So like here, tuberculosis isn't a big deal, but it is there. So as a radiologist, you kind of have to know that too. Like I did training in Winston-Salem, North Carolina, where everybody smokes and lung cancer is really prevalent. So you're going to be more likely to say this is lung cancer. So a lot of working knowledge. This is a cool picture with two cheetahs that I took. Let's move forward. You get to do a lot of education. So we have medical students come, even pre-med students come and shadow us. And then residents in particular, that's where the real teaching happens because it's pretty advanced radiology to some degree. Like it's not something you learn a ton about in medical school. So it's hard to really appreciate when you're watching other than just kind of get an idea of, you know, does that look like interesting to me? But we do a lot of one-on-one where you really teach people even up until this past year for me. So this is a big mass in the drainage part of the cerebrospinal fluid, that fluid I was talking about in these things. And these are the ventricles. I know you don't know the anatomy is not important, but these are too big. And the reason is because this mass is blocking the fluid from getting out. So we basically tell them, what do we think it is? And then they'll go and biopsy it. And that's that. And then they put this, it's hard to show, but they'll put a tube in here called a ventriculostomy catheter, which will drain it and take the pressure off. So this doesn't squeeze on this brain too much, because if there's too much water in here, the pressure gets high and it pushes on the brain, and then you can get brain damage. So it's important to look at those, and that's part of our job. Are the ventricles too big? I'm gonna skip this mass. Hey, calm down. Let's skip. This is kind of some more impressive stuff that just to go again with what do you find in certain places. So Epstein-Barr virus is more common there. And for some reason, in some African and Asian populations, it causes this cancer in the throat called nasopharyngeal carcinoma. So let's see if I got a more impressive one here. Yeah. So I had this case over there, and this is the nasopharynx. Just trust me, this is a lot bigger than this side. That's a mass, actually. And they didn't give me the right images, but I kind of was wondering if there was some abnormal brightness here in the brain. So I went back and got them to manipulate the data and make it soft tissue algorithms so I could see it better. That's part of what we do. And there's this big mass here. Just trust me, this is the normal side. This is the abnormal side. And it's actually invading the brain here. And they had no idea. So it's pretty cool to be, I mean, it sucks because you're like, a lot of times it's bad news, but you're at least giving them answers and they can work on the treatment. And sometimes you're really saving people. This is another of the same type of case. All this bright stuff is abnormal lymph nodes, and they actually did a biopsy here. But you're just looking, it's just amazing to look through somebody's body and look at all these problems very quickly. This is abnormal bone. It's too bright here compared to the rest of it. It's being infiltrated by the cancer. And we have to talk about all that. So this was an interesting case, actually. This guy came in, he was like 30 years old on his motorcycle, totally healthy looking guy. And he had this mass, which you could kind of see, even just touching it or looking, but he had this mass and they told him it was this benign mass, and it kept bothering him. And we were like, whoa, this mass is actually going inside the mouth. If you can believe me that this bright stuff is abnormal, and there's abnormal loss of the white bone here. And then we took more pictures of it. This is a bone window where we can see the bones more. See, the bones look all white here, but you can see different shades of gray here, and it's eating away at the bone. So we were like, I don't think this is a benign mass, and it's actually going inside the mouth here. And then we found some abnormal lymph nodes back here. Not important, but the point is, like, you can figure out what stuff is if you really sit there and think, and you can be a really good radiologist, you can be a really bad radiologist. So it's a cool field. It's a hard field, but it's if you put the work in, you can do it. And we actually found a bone metastatic lesion here. Sorry, I'm kind of flying through, but I know some of these pictures are going to be too hard to explain. Just doing a lot of teaching. This is a big orbital mass here on CT. This is a cool picture. Another cool picture. I'm going to go to the other PowerPoint real quick for the last 8 minutes or so. Let's see. Got this. Now my puppy's being quiet when I am trying to. Okay, so I got the non-neuro cases, and I'm gonna open Zoom back up and share my screen. All right, can you see that? Probably, hopefully. Let's go full screen. All right. So these are just pictures of other parts of the body because I loaded you up with brain and spine because that's my specialty. And these are CT heavy because they're from Kenya, but I thought they were pretty cool looking cases, some of them. This is just a huge tumor that was coming from this person's hip bone, this tumor. It was actually going all the way up into their belly, and it was eating, this is part of their colon, actually. And they were actually getting stool coming out of the tumor. So it's kind of impressive in a kind of gross way. So that's a big tumor that we get to see. We're the ones who have to tell them what we think it is, what's it invading, etc. Let's skip this case.
What ended up happening with her or him?
Well, unfortunately over there, a lot of things are lost to follow up. In that particular case, we weren't there long enough to follow up with it, but that was definitely we think it was a chondrosarcoma based on based on the fact where it was coming from, what it looked like. It had some, what we call chondroid matrix. There's a lot of clues. It's really cool, the problem solving, that it's kind of hard to explain that to you, without looking. I'm going to skip that case too. I'm trying to get some impressive. This was a cool tumor case in the stomach. We don't see a ton of tumors. This is a tumor right here. So as you're looking through the stomach and then you're looking at the liver, you're like, whoa, that's abnormal. What is that? And then you figure it out, and then you have to figure it out. Here it is right here. With radiology, it's really good to like follow up, just like anything, to follow up your work and see if you were right, see if you were wrong. What did that turn out to be? And that's part of being a good doctor in general. Here's another big stomach tumor. I mean, we saw some gnarly stomach tumors. This probably ended up being a GIST tumor. This whole big ball is not normal. This is like normal looking stomach over here with this like rim of bright, and then the inside is just like food and stuff. But this is like a big solid mass. You can see it. This is a whole big, sorry, my dog is hitting my hand. This is a big solid mass here, and they won't be able to swallow. They'll throw up, etc., because of the mass. And then somebody will be like, let's get a CT. And they'll be like, he's probably just being a whiner. And then you're like, whoa, there's a big mass. So that's how radiology works. This was a really impressive mass here. This is just the scout image. You can see this mass taking up like most of the abdomen. I think this one might have ended up, we actually weren't sure what this was. It was a kidney tumor, we're pretty sure though. And there's like clues as to why it might be a kidney tumor, which I won't go into, but we can look at the way things look in terms of shape and characteristics. I'm not really going to based on MRI, but MRI is like takes it even to the next level. I love MRI. I think it's the coolest thing. This is a case that has some on the CT. There's these little abnormal nodules, these abnormal little white patterns here. Hey, shh. He's not normally like this, guys. I'm sorry. But you can see that this lung is like smaller. It's actually lost some volume. See how much smaller it is than this one? Hey, and then there's, this is abnormal, like volume loss down here. That ended up being tuberculosis, which you see a lot of over there. I'm trying to show you a couple. So this is the biliary duct. This shouldn't be so big. This is like where the bile drains. And this person had a mass right around here. And it's a pretty impressive case of, you can't see the mass very well, but you can see how the bile ducts are too big. So that makes you know there's something wrong where it drains. And that's how radiology works. Like sometimes you'll see one thing and it'll make you look, for instance, if you see a tongue that's like on the x-ray or on the MRI that's all fatty, then you're like, whoa, that tongue is probably lost its nerve, like the function, because it's not working anymore. And then you go back and look at the skull base where the nerve is and you see if there's a mass there. Hey, calm down. All right, this is another bile duct one where these bile ducts are too big, and that gave us a hint. Let me get to the more impressive cases here. This is a huge mass here that kind of almost looks like the liver, but this is an abnormal mass that basically just goes to show that in Kenya they just wait too long to go to the doctor because nobody can pay for it, and it's all out of hand. It's all out of pocket cash. This is a huge mass. I think this was a kidney mass too, actually. This is a colon tumor right here. The colon goes up on one side, over, and then down on the other side. This is a big colon mass. These dark spots in the liver. These are metastatic disease. So, you start to learn how the body functions. So you have like blood goes through arteries to the organ, and then it drains through the veins. And so cancer follows that, and cancer follows the lymphatic channels. So you know that the colon ends up draining blood to the liver once you go to medical school, and the lymphatic systems follow that way. And so you kind of know where to look because of the knowledge you have. So it's not just looking at pictures, it's having a lot of knowledge. And it's a lot of experience as well. So this is the mass, and these are the metastatic lesions. And you just start seeing patterns. It's all about pattern recognition. Let me see this case. Let's skip. Actually, this was an interesting case, actually. They came to me, and this guy got hit by some kind of like cart or something like 5 or 6 days ago. And they're like, oh, he's probably just being he had some bruising. And then the guy comes up to me and he's like, oh, he's probably got this or that. And I was like, yeah, let me look at it first, the ER doc. And he was real confident. And then I noticed I'd never really seen this before, but this dark line going through the pancreas, he actually like basically ruptured his pancreas. He lacerated his pancreas. And all this, you'll just have to trust me because it doesn't make sense to you, but all this extra like kind of dark stuff around is actually pancreatic enzymes spilling into his belly and destroying things, because it's like basically like a chain reaction of acid almost. I heard about a story about somebody bench pressing, didn't have a spot, and it ruptured his pancreas. He ended up dying because it just like started eating away everything in his belly. So, you don't find that. They don't go to surgery. You might not stop it, and they might, destroy other stuff, and it gets out of control. So this is the thyroid. Unfortunately, this is a very abnormal thyroid. The bright stuff is normal. All this dark stuff is cancer, and these are big cancerous lymph nodes from thyroid. So, you know, somebody would be like, oh, they have a little bit of fullness in their neck, and we'd figure out, oh, this is probably metastatic thyroid cancer. Or we'd say it's just a normal looking nodule. This is another tuberculosis case. I'll just run through a couple more pictures here. Tuberculosis is really impressive disease when it's causing these like cavities. These are actually cavities, and these are like, this is like fluid here layering with air here. So it's like literally big old half-filled water bottles in your lungs, cavities created by tuberculosis eating away your lungs. Let's see, more tuberculosis. I'm trying to show you. This was a cool case. So we looked through abdomen and pelvis. This person probably was throwing up, couldn't eat any food. And these, you'll just trust me that these are small bowel loops, and they're a little bit big. And then we noticed one of them was kind of being twisted through this hole in the front of the abdomen. So imagine this is like somebody lying down, and this is their front and this is their back, and we're doing a cut through them horizontally. This is actually a hole in their abdomen, a hernia, if you will. And this is the bowel going through and getting twisted like the way you would like twist the bottom of a balloon. And it's blocking the bowel. So nothing that's coming in here can get out. So it's basically causing a small bowel obstruction. So we figured out where the problem was. They can go and fix the hernia. Maybe they can push it back in the ER, and that's what happens. Here's another mass. This is actually a mass from a parasite, and it has this characteristic calcification, which is this bright stuff around the sides. It's a hydatid cyst, something you don't see much in America. This is like a plain film showing these loops of bowel that are too big. So not even showing you MRIs and ultrasounds. There's a lot of different pictures here. This is fluid. I'm gonna skip past some of this stuff. Try to show you one or two. This is a really cool case that I can't explain to you because it's too advanced, but this is all like calcification blocking the kidney. And just like in the head where those big fluid filled things got too big, that can happen in the kidney, and this kidney can die basically. And we can figure that all out from the pictures. And then I just wanted to show you one more case of tuberculosis because it was kind of cool. Oh yeah, the one other thing real quick is that people, they get like broken legs there and they don't get fixed. People are like crawling around. They're like crawling into the ER, crawling into the CT scanner. I mean, this hip joint is like destroyed. It's supposed to be down, like lower down here, and it's like destroying the bone and going up into the hip. This was a ruptured abscess in a little kid. So this little thin wall of brightness is supposed to be there, and it's gone here. This loop of bowel actually ruptured, and then this is all fluid, and we found it with an ultrasound, and people were like, oh, he's fine. We're like, no, he's about to die actually, if you don't treat him and drain that like right now. So let me see if I got anything else cool. This is an example of like what happens if you get injury to the bone and you don't fix it, and then it gets infected and it starts getting all this like deformity. And sometimes they just have like floating. I mean, look at this bone. This is supposed to be like a straight bone. That's what we call osteomyelitis. And then I just wanted to show one more thing. So this is, no, that wasn't it. Oh, I skipped it. Well, anyways, tuberculosis can affect your spine. It can affect your scrotum. I had some pictures of that, but that's pretty much all I got. There are endless amount of pictures for radiology that you can look up online and stuff. My main point, as far as the experience, is it's very diagnostic heavy. It's very broad, lots of information, solving the puzzle, doing procedures, and, you know, getting to see cool cases, being efficient and good lifestyle and good money. And that's radiology. If you have to treat somebody with chemotherapy, it might not be the field for you, but it's worth checking out. And if you're a doctor of any sort, or a PA or a nurse, it's good to have at least some basic background and understand that it's important to follow up on the reports for your radiology studies. And that's all I got. I'm gonna turn it back over to him, or any big questions.
Yeah, thank you so much for sharing all that information.
Sorry about the dog here. He's
okay.
not like.
There's a lot of people saying the chat is cute, so
yeah, here you can get a little look.
I got a couple of questions that I want to ask you that were in the chat. Going back to your residency,
yeah,
how exhausting was your radiology residency, and how did you get to go to Kenya during your residency?
What was the first part? Did you say how exhausting? What did you say?
Like, was it exhausting? Like, could you talk
Okay.
about this
So I will
experience?
say that radiology in general is not an hour heavy field. So when I take call in residency, it is intense. Like it is like taking the MCAT. Not that crazy because I'm not like studying for new stuff all the time, but it's like you're moving, you're getting phone calls because everybody wants to know the answer. They want to get the patient out of the ER. Wake Forest is a hard radiology residency. So radiology, you're not working 80-hour weeks. You might be working 50, maybe 60, but you have to do more studying on the side. And to be honest, it is, especially when you're not super experienced, it's hard to shut your brain off after because you're going fast. You're like looking, you're like, where's the brain? So it's a hard residency in particular at Wake Forest, but I feel like I got really good training. So my life is easier now because I'm like super efficient. So it's a trade-off. It's hard, but I mean, I'd much rather be doing that than I did an ENT sub-I at an institution I won't name because they could get in trouble, but I worked 120 hours my first week. Okay. I was home for like less than 4 hours. It was completely malignant. So it's nothing like that. Radiology is on the medium to better lifestyle in terms of even for training. And fellowship is a little better, and attending life is even better. So it's not the easiest. I would say go dermatology or maybe radiation oncology if they still have good jobs, but it's a lot easier than doing like surgery.
Okay. And your experience through Kenya, was that like kind of just an opportunity that was given to you?
Yeah, so I'm a big traveler, so I was like looking into it. It turns out that there's an attending there, and our sister had a connection. So they've been sending people out, specifically at Wake Forest, to do radiology for like 10 years now or so. And they're really cool. The second year, they kind of wanted me to become like adjunct faculty so I could take residents there because it's harder for them to get staffing than it is to send residents.
Oh.
And they have tried to branch out and work with other institutions. Like they wrote up a paper with Harvard, and they're trying to get Vanderbilt on board with it too. So they're trying to get full coverage over there, but they do it at some other hospitals. It's one of those things where you find somebody that knows how to do it, and it becomes easy. It was a lucky opportunity. It's not like it's going to be there at every residency.
Okay. So
But you can make it happen. There is something called like Rad Aid around the country and stuff that works on this kind of stuff. And I got a bunch of scholarships. Like I got a ACR, American College of Radiology. That's like the biggest whatever it's not the people who do the board exams, but they gave me like scholarship. Like people don't know there's scholarship money out there. Like literally Doximity. If you guys have heard Doximity, I applied on Doximity for my second trip. I wrote like 2 or 3 paragraphs and they paid for my flight, you know?
Oh, wow.
So there's stuff out there. You just kind of have to take some initiative.
To look for it. But
yeah,
that was great. I'm just gonna wrap it up real quick here. Thank you so much. First of all, thank you so much for your time and coming in. I think that was a lot of cool cases that we got to go through. And
yeah, sorry if it was too much, too fast, but I more just wanted to give you the idea of kind of like what I'm thinking.
But it was cool. It was cool. But before we close, I just want to say something. So today was our call with radiology, and we'll continue to have weekly calls. And for you to stay updated, just keep looking at our Instagram, and we put information out there in terms of when the call is going to be and what's it going to be and how it's going to be done in terms of what it is. So if you want to stay up to date, it's through Instagram. And if you guys have any questions about anything, DM us. And if you guys want to ask him more questions, where can they reach out to you? Instagram?
Yeah, so feel free on Instagram. All my handles are at Tommy DeFato. I don't know if you had that up. I was trying to find that. But I'm getting situated. I got a new puppy. I got a new town, but I was starting to do like TikToks on it too. So I don't know. Is that how you approach me from? I don't even know.
Yeah, I think so.
I did a TikTok on how to get into
the chat. I'll put it in the chat for everybody real quick.
Yeah, I can do. Yeah, I've got that one. I have that one TikTok that people liked a lot on tips on how to get med school. Just for everybody's information, I did not get into medical school my first try. I thought it would be just like I'll just real quick. I thought it would be like have good grades and have a good MCAT. It's really not what that's about. You have to be well-rounded, research, all that stuff. You can check out my TikTok for what my thoughts, but it's basically, I try to like tell people what I screwed up, because I did get in my second try. I kind of got lucky on that but it ended up working out perfectly. I got a scholarship. So, if you feel like you might not get in, there are other things you can work on. It's not all about GPA and MCAT.
There you go.
I think, did I share my screen? Yeah, I was just sharing it because I think I have my handle on there.
Okay. You guys, we're gonna.
I'll shut up now.
Yeah, that's no, you can say. But that's it, guys.